Hello everyone, welcome to Radiology Case Review Series. In this video we are going to look at a young male patient who presented to emergency department with fever and chest pain. Patient initially underwent chest radiograph examination in the emergency department. On the chest radiograph we can see some patchy opacities, most conspicuous in the right lower zone. Patient was very unwell, so clinical team decided to proceed with CT of the chest for further characterization. On the CT chest examination, we can see multiple cavitary lesions in bilateral lungs. There is also a moderate size pleural effusion with adjacent consolidation in the left lower lobe. Findings are concerning for septic emboli with possible empyema in the left lung. The clinical team noticed that patient was also complaining of left-sided neck pain, so they decided to proceed with CT soft tissue neck examination. On the CT soft tissue neck examination, we can see there are bilateral rim-enhancing collections in the peritonsillar regions of the palatine tonsils consistent with peritonsillar abscesses. Also notice that there is a tubular hypodense structure in the retromandibular region consistent with retromandibular vein, which is likely thrombosed, extending into left internal jugular vein, which again looks thrombosed with rim-enhancing wall. We can see similar findings on the coronal reformats where there is thrombosis of the left internal jugular vein with rim enhancing wall consistent with septic thrombophlebitis. So we are dealing with a young male patient who presented to the emergency department with fever, chest pain and clinical picture of sepsis, where the chest radiograph initially demonstrated patchy left lung lesions. On the subsequent chest CT examination, we see multiple cavitary lesions in bilateral lungs with moderate sized left pleural effusion with dense consolidation of left lower lobe, possibly suggestive of empyema with underlying consolidation. On the CT soft tissue neck examination, we saw bilateral peritonsillar abscesses, thrombosis of the left retromandibular vein extending into left internal jugular vein, which shows enhancement of the venous wall consistent with septic thrombophlebitis. Appearances are consistent with Lemierre syndrome. Fortunately, Lemierre syndrome is less common now with antibiotic use. However, because it is not seen frequently nowadays, the diagnosis can be delayed. Also, the presentations can be atypical if patient has taken antibiotics. Lemierre syndrome is classically seen in young adults, predominantly in males in the age range of 16 to 25. Patients usually present few days after acute head and neck infection. Patients can be very sick. Although the mortality has decreased, it is still in the range of 2 to 3%, particularly considering the fact that this happens in healthy young patients. The mortality is pretty high. Classically, they will present with trismus and pain behind the angle of jaw, as we saw in our patient. So as we saw in our patient, Lemierre syndrome is described by septic thrombophlebitis of internal jugular vein with distant emboli. Classically, the emboli happens in more than 90% of the patients to the lungs, where they can have cavitary lesions, lung abscesses and empyema, as we saw in our patient. Rarely, the septic thrombophlebitis of internal jugular veins can extend cranially, where they can have septic thrombophlebitis of cavernous sinuses and transverse sinuses. This is sometimes referred to as reverse Lemierre syndrome, and this can happen in up to 20% of the patient. In up to 25% of the patient, they can have septic arthritis. Rarely, they can also have liver abscesses. In our patient, the blood culture showed Fusobacterium necrophorum, which is one of the commensal organisms seen in the oral cavity. I hope you found this case to be informative. Thanks for your attention.